Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 15. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. Article 15, Pain is Not the Only Problem. Explaining pain. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction in clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient satisfaction on the first visit at low cost. Is it possible to explain pain in a way that meets all of the demands of the clinician and the patient? Throughout these articles, we have been exploring the definition of pain and have learned that pain is a sensory experience of the patient and that the sensory experience can be real or imagined. We also learned that the pain might have a traceable origin to the site of an injury or not to the injury, or from no source at all. We also learned that the sense signal called pain that the patient experiences is not felt at the site of the injury, but rather felt in central processing as an interpretation of pain, with a cognitive assignment of pain to the injury site, a seemingly sensible and useful process. Should the clinician explain this phenomenon to the patient? I do, but it's up to you, and I explain that their course of care will certainly deal with their symptoms. Diagnosis is largely an act of medical discrimination because it is commonly reductionist and non-inclusive and does not explain the entire patient. Medical discrimination describes the overly common practice of diagnosing with a very small scope of codes that are familiar to the clinician's scope of practice and does not require a great deal of effort. These easy codes, such as S39.92XA, unspecified injury to the back, and M62.830, back pain. Well, what about M46.06, enthesopathy, or M51.86, lumbar disc disorder? And then M79.2, my favorite, neuralgia, explains nothing about the patient's problem. The problem is not the pain or the symptoms. The clinician should be diagnosing the problem and informing the patient of something that they do not already know. A diagnosis of pain, numbness, tingling, radiation, weakness, acute inflammation are descriptions of patient presentation for the chart or the SOAP notes, but not for the diagnosis. Medical discrimination describes a reductionist and non-inclusive approach, since the diagnosis only explains a few injury-directed codes. It does not explain, for example, R26.89, gait abnormalities, Y93.01, impact on walking, hiking, and running ADLs, M99.86, biomechanical lesion, M25.66, knee stiffness, M25.37, ankle instability, Z72.3, lack of exercise, and R29.3, malposture, for example. The clinician's role is to explain a complete picture of the patient at the moment of reporting the low back pain injury or complaint on the first visit without delays of pending diagnosis waiting for endless imaging and referrals. Since 90% of the diagnosis is embedded in the history, the physician simply needs to ask the best, most useful questions and provide a complete diagnosis that represents and explains the low back pain injury. A diagnosis of back pain does not explain the injury. When the physician focuses only on pain and its direct relationship to an injury, the problems begin to arise. Traumatic low back pain is easier to explain than non-traumatic in the clinical setting, many times attributed to an event such as a fall or a motor vehicle accident, and may include tissue damages like burns or fractures. However, traumatic low back pain may involve, for example, SO6.2X, traumatic brain injury, SO6.0XO, concussion, G44.3, headache, F32.0, depression, H81.1, vertigo, for example, that is not clinical and should not be oversighted since it explains the entire patient. Other diagnoses should be included when diagnosing a low back pain patient, not just a diagnosis related to low back pain. Low back pain may be attributed to clinical pathogenesis such as arthritis and inflammation of the hip, M13.859, or knee, M13.869. Non-clinical low back pain may involve systemic bone pain or tissue injury such as muscle pain. However, these are sense signals and not a diagnosis that explains the pain or the problem. Neither event-based low back pain trauma nor low back pain pathogenesis can explain emotional pain, like that of grieving, pain that feels loud, amplified, and crushing. Neither can they explain mismatched pain, intermittent pain, and pain with no historical or clinical basis. Nor can they explain pain that persists beyond healing, or when there is no stimulus such as in phantom pain. How can the clinician insist that a disc herniation is a causative factor for low back pain while having no explanation for phantom pain? Worst is pain brought on by surgical failure, since it can be difficult to explain and discuss with the patient. Can an afferent signal arrive at the brain that is dedicated to describe pain only? Absolutely not. Is there a part of the brain that detects and processes only pain? Absolutely not. Are there neurons in the brain that are pain-specific or pain-selective? Absolutely not. Can you think of any other areas of the brain that might light up along with a signal of pain? Consider these: paying attention to the pain, behavior association and modification due to pain, such as antalgia, facial and vocal displays of unpleasantness, pupillary changes, agitation, irritation, shortness, brashness, defensive motor mapping, changes in self-care management, social changes, co-related frustrations like worry and loss. Clearly, the physician must explore all of the clinical and non-clinical diagnosis related to low back pain and pay close attention to the non-clinical contributions to low back pain while explaining this thing called pain to the entire patient, since pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.